Thank you, Rob. Okay, so I guess we'll go ahead and get started. So today I'm going to talk to you a little bit about cardiac MRI, basic principles. And then throughout the course of the year, we'll have a series of lectures which will incorporate cardiac MRI. And I think the way that this series has been structured now is instead of focusing on modality, it's more focusing on disease state. So focusing on valvular heart disease, and then what's the role for echo, what's the role for MRI. And because that's really the way I want the fellows to start thinking about imaging, not so much as MRI versus CT, rather think of it as a patient who needs imaging for a certain condition, and then what's the best scenario in which you can accomplish that. So first question, this is a quiz. Who are these two guys here? They look like two professorial types, right? Does anybody know who hasn't seen this figure before? No? Okay. Nick? Well, so I've got the names. So what does it mean? Who are these guys? So Peter Mansfield, Sir Peter Mansfield and Paul Lauterberg. These are two PhDs that actually were given the Nobel Prize in Physiology and Medicine for their discoveries regarding MRI. So these are the guys that are kind of the founders of MRI, kind of like Grunsig would be the founder of angioplasty. So I guess maybe they're not quite as famous as Grunsig is. I guess MRI is not as hot as intervention. But so, you know, the prize was in 2003, but the work they did was really in the 1970s, okay? And so it gives you an idea of how long the field has been around and how it's evolved over time. Now, here's an example of an MRI scanner, what it looks like. So people always ask me, oh, do you have an open scanner or a closed scanner? Well, so for cardiac scanning, this is what's called a closed scanner, okay? So it means there's a bore, the patient lays on the table, and they go inside. All right, so the table actually moves and puts the patient inside. But it is open on both ends, but it's different than a truly open scanner where there's just a piece on top and a piece on bottom, and it's open completely on both sides. All right, so this is a 1.5 Tesla scanner. This actually is a picture of the scanner we have over here in Main 2. We actually have two scanners, one here, and then a second one over in the outpatient center, which is a 3 Tesla scanner. And so if we look at kind of the timeline of cardiac imaging, I think cardiology is lucky in that we've really had a lot of imaging advances over the last 30, 40 years. With echocardiography coming around in the 1970s, nuclear cardiology in the 80s, and then I like to think of cardiac MRI as a technique that's reached its mainstay, I think, in the 21st century. And today, you can use cardiac MRI for not just 1 or 2 applications, but rather for a diverse variety of applications. It allows you to do anything from looking at valvular heart disease, looking at cardiac masses, looking at perfusion of the myocardium, tissue characterizations to look at RV dysplasia or myocardial viability, pericardial diseases, anomalous coronaries, and then also, importantly, vascular heart disease, aortic diseases, and peripheral vascular disease. So what I'm going to try to do here is talk a little bit about the basics behind MRI physics, talk a little about MRI contrast, spatial resolution, and then just briefly touch on the pulse sequences that we utilize. And again, the first thing I want to do is make sure I don't put everybody to sleep. So I'm going to try to make this as a kind of a high-level overview of how cardiac MRI works. So, from the most basic standpoint, it's really 2 things, all right? It really involves basically a magnet and radio waves that are being transmitted and received. And it's using those 2 basic things to allow you to generate an image. Now, obviously, there's a lot of steps in the middle. And if somebody wants to really get into the weeds, we could spend, days and days just talking about how the MRI signal is actually accomplished. But I think, if we look at it from a high-level perspective, there's a couple of things. So one is obviously the magnet coil itself. So that little donut-type machine right there, that's the main magnet, okay? Now, you also have within that main magnet, I'll show you gradient coils, which basically cause a slight distortion to the magnetic field. And then there's also radio wave transmitters and receivers, okay? So, and again, these are the basic fundamental things that you need to do MRI imaging. Now, so the main magnetic field, okay, so that's a very strong magnetic field, and that defines the strength of the MRI system. So that can be either 1.5 Tesla, 3 Tesla. Now, in the early days, they were even lower field strength, so there were scanners that were 0.2, 0.5 Tesla. And now, today, there are scanners that are as high as 11, I think, or 13 Tesla scanners. But for most clinical use in humans, it's going to be primarily with 1.5 or with 3 Tesla scanners. All right. Now, so when we talk about 1.5 Tesla or 3 Tesla, what exactly does that mean? So, and also that's what we refer to as the B naught. So that's the strength of your static magnetic field. Okay. So B naught is what it's referred to as. And so basically, 1 Tesla is equal to about 20,000 times the Earth's magnetic field. Okay. So 1.5 Tesla would be about 30 times the strength of the Earth's magnetic field, and a 3 Tesla scanner will be about 60,000 times the strength of the Earth's magnetic field. Okay, so that gives you kind of a scale of the strength of the magnetic field that we're dealing with. Now, the other thing I talked about, remember, is that in addition to the magnetic field, there's these gradient coils that basically cause a slight distortion to the magnetic field, either to make the magnetic field slightly stronger or slightly weaker at a given specific location. And so these gradient coils are actually within, again, that bore of the scanner, and the gradient coils are actually existent in 3 different directions. So there's a set of gradient coils that are in the transverse or Z axis, a set that are in the X axis, and a set that are in the Y axis. So really there's 3 different gradient coils that are present within the bore of that scanner. And then it's a matter of how you play those different gradient coils that allow you to cause gradients or alterations in the magnetic field at different locations inside of the magnet itself.
So, Dipan, what are they made of?
So they're basically electrical wires. They're electrical wires that are twisted around in such a way that when you send electricity through it, it actually causes a magnetic field to form.
So magnetic field within the magnetic field.
Right, so it causes alterations to the magnetic field. So there's a static field, which is the 1.5 Tesla, and then these gradients, as you apply them, they cause a slight alteration to the magnetic field in a linear fashion. Okay, now, so when we define what the strength of a scanner is, we define the field strength, which is 1.5 or 3 Tesla, but then you also talk about what the strength of the gradient is. And so the strength of the gradient is defined as millitesla per meter. So it gives you an idea of the scale of the distortion that you're doing. So if I have a gradient in the Z direction, right, going from head to foot, and I apply that gradient, and it's a 1 millitesla per meter gradient, that means that if I'm at the center of the magnet, the field strength is 1.5. If I go 1 meter further away from that, the field strength will be 1 millitesla more than that. So it's very small alterations in the magnetic field that you're creating, but you're able to do that in all 3 directions, in the X, Y, and Z direction. And so that's a parameter that when if you're purchasing hardware, you're going to look at. What is the strength of your magnetic field? So the strength of most magnetic fields that you need for cardiac imaging are on the order of about 40 to 45 millitesla per meter. Okay, so the stronger the gradient, the better, the faster the performance your system can give you. The other thing that's required, so the gradients cause a distortion to the magnetic field. The other piece now is the RF, radio frequency waves, okay? And there's 2 things to keep in mind. There's a transmit RF coil and there's receive RF coil. So just like a radio station, right? It transmits somewhere, and then you have an antenna. You have a antenna that actually receives the RF waves. So the transmit RF coil is actually present within, in most scenarios, within the bore of the scanner itself. So that actually transmits a radio frequency signal in to the body, and then in addition to that, so that coil that's within the bore of the magnet can also receive signal. But you also have superficial coils that you can place on top of the patient or right behind the spine that can actually receive signal. So these are receive RF coils. Now, the question you'd ask is, okay, why don't, if the bore of the scanner itself can transmit and receive radio frequency signals, then do I really need to have these coils placed close to the body, right? And the reason you do is because remember, it's just like if you've got your radio, right? The closer you are to where the signal is being emitted from, the better you're going to pick it up, right? So in this scenario here, the bore of the scanner is transmitting the signal to the body. The body receives that energy, and then it begins to emit a signal back. Now, the closer you are to the area that you're interested in imaging, the better signal you'll get. And that's why we try to place the coils as close as possible to the region that you're interested in imaging. And that's why if you want to, if radiologists are doing imaging of the hand or something, they have a very tiny coil that they place right on top of the wrist, right? Because the closer your coil is to the area that you're interested in imaging, the better the signal you're going to get. Okay. Does that make sense?
But that coil would only look at that structure that you're interested in.
Right. So the issue is the closer you are and the smaller your coil is, the smaller the surface area or the smaller the area field of view that you have, right? You get better signal noise, but you get smaller field of view. If you want higher field of view, you need a bigger coil. That comes obviously at the expense of worse SNR, worse signal to noise. But again, the basic principle is the closer you are, the better signal you're going to get. Okay, and then the magnetization that's caused locally. So remember, we said B naught is the static magnetic field, and that's 1.5 Tesla or 3 Tesla. When you apply gradients, you cause an alteration to the magnetic field, and then that now becomes your B naught. So whatever or B1, I mean, that's what the magnetic field is at the specific location that you're talking about. So within the body, that the altered magnetic field that the body sees is what's called B1. Now, why is this important? Well, remember this equation, okay? This is, anybody who's doing, kind of even, MRI Physics 101, you need to know this equation right here, which is called the Larmor Equation. And basically, all protons, when they're placed into a magnetic field, will do something called precession. They precess, that means they spin around, okay? Just a fancy name for spinning around when they're put in contact with a magnetic field. Now, how fast do they spin around at? Well, how fast they spin around at is really a function of the magnetic field. So the higher the magnetic field strength, the faster they're going to spin around at. The slower the magnetic field strength, the slower they're going to spin around at. And so the Larmor equation basically just simply says the frequency of precession of protons is equivalent to this gyromagnetic ratio times the local magnetic field, okay? And so, for example, at a field strength of 1.5 Tesla, now that's gyromagnetic ratio here is 42 millihertz per Tesla. If you multiply that by 1.5 Tesla, you get a precession frequency of about 64 megahertz on a 1.5 Tesla system. On a 3 Tesla system, you have a precession frequency of 128 megahertz. So you're dealing in a different range of frequencies when you're at a 3 Tesla versus a 1.5 Tesla. But this is kind of the base range of frequencies, and then when you apply a gradient, you'll cause those frequencies to adjust slightly so that you'll make it 64.001, 64.002, or on the flip side, a little bit less than 64. Or if you're 3 Tesla, in the range of 128 plus or minus a small amount. All right. Now, so then this is the net effect then is that, but when you place a patient into the magnetic field, the patient's body itself sees magnetization and therefore has a alteration in the magnetization of the protons within the body. Now, what a gradient does is it actually applies a magnetic field in a gradient fashion so that the alteration of the magnetic field will be different, for example, at the head versus at the feet, right? So that's what a gradient's doing. So if I'm at 1.5 Tesla, that means I'm at a frequency range of 64 megahertz, and I cause a slightly higher gradient, meaning a slightly higher magnetic field here, then the protons at the head maybe are spinning at 64.002 megahertz. The protons at the feet, on the other hand, may be spinning at 63.999 megahertz, right? So slight difference between the two. And then we'll talk about how we use that information to both selectively excite only a specific slice of interest, and also how we use that information to actually encode for spatial location on our MR image. Now, the other thing also that's important to keep in mind is that, remember, excitation really involves a transfer of energy, right? So if I have protons that are spinning at 64 megahertz, and I send in a radio frequency wave at 64 megahertz, those protons will get excited by that radio frequency wave, and they'll absorb that energy, and it will cause them to go into a slightly different excitation state. So if I apply a 90-degree flip angle here, the protons that were initially precessing in the upright fashion will now begin to get excited because they absorb that energy, and all of a sudden now they'll get tipped down into the transverse plane, and they're still spinning around, but they're spinning around at a 90-degree angle from where they were spinning around at before. And then what will happen then is that those protons will then release that energy back, and as they release that energy, it sends an RF signal back, and as they go back up to their resting state, there's a radio frequency signal that gets emitted back. All right? But the important thing to keep in mind is that if I send in a frequency of 64 megahertz, only protons that are spinning at that frequency will actually get excited. So the way you can think of it is like if you have a pendulum that's swinging back and forth, and if I'm hitting this thing, but if I'm hitting at the same frequency that the pendulum is swinging at, I'll keep exciting it, right? But on the other hand, if the pendulum is here, I don't hit it until the pendulum is here, I'm at a different frequency than what it's at, it won't actually get excited. So only tissues that are spinning at the same frequency that you transmit or you send in will be the ones that actually get excited, will actually receive that signal. Okay, and then whenever they receive that energy, that then takes them from the longitudinal state, which is the normal resting state, into the transverse state. And the transverse state is what you use to actually receive MR signal. So you have to go from the z-axis to the x and y axis to actually be able to receive MR signal. Now the thing is, we can change what the z-axis is and what the x and y axis are, right, depending upon how you apply the gradients. So you're not limited to say, okay, I can only do axial imaging or sagittal or coronal imaging. You can pick any imaging plane that you want. But the basic principle, I think, is that you go from that resting state to the excited state, go from the longitudinal plane down to the transverse plane. Now, what happens once these protons get excited is that eventually there's two forms of relaxation that occur. There's, when you've taken protons that were upright in the z-axis and you've driven them into the transverse plane, what will happen now is these protons initially are spinning around together, but gradually they'll start to spin around at slightly different frequencies, and they'll eventually become separated from each other. And you can think of this as if you have an auto race. In the beginning, all the racers line up at the starting line, and they're all going around the track together. As time goes on, eventually some are faster, some are slower, and as a result, you actually now have a dispersion. And that dispersion then leads to what's called a T2 decay. So this is the decay or relaxation in the transverse magnetization that occurs over time, and that's T2. And the T2, by definition, is the amount of time that it takes to decay your magnetization to 37% of what it was when you first drove it into the longitudinal or into the transverse plane. Now, this is tissue specific, so that the rate of decay, the rate of T2 decay is different for water versus myocardium versus blood versus fat, okay? And then you've got the second phenomenon happening at the same time. One is you have a decay in the XY plane. You also have a regrowth in the Z direction or the longitudinal direction, because again, once you stop applying that radio frequency wave, the tendency is to go back to the resting state, and the resting state again is in the upright or longitudinal plane. And so this again now is what's called the longitudinal relaxation that occurs, and this reestablishes your longitudinal magnetization. And again, this will happen over time, and the rate that this occurs at is also a function of the tissue. So fat has a certain T1 relaxation or recovery time compared to myocardium, normal myocardium compared to water. So they all have slightly different times. And then the T1 is defined as the amount of time it takes to regrow to 63% of your resting magnetization. So if you started out at +1, you apply a 90-degree pulse to drive the magnetization to the transverse plane so that there's 0 longitudinal magnetization. The amount of time that it takes for you to get back to 63%, that defines your T1 time. Okay, now, so again, the range of T1 values are different. So for lipids that have a tumbling rate which is similar to the Larmor frequency, you have fairly fast relaxation, and therefore the T1 time is short. So again, if I go back here, fat recovers very fast, so the amount of time it takes for it to get back to 63% is very little. So it's on the order of a couple hundred milliseconds, compared to something like water, which has a faster tumbling rate and therefore slower relaxation, and therefore will have a long T1 time. So if I go back here to the previous graph, you can see water, the rate of T1 recovery is much slower, so the amount of time it takes to get back to 63% of your magnetization is much longer, on the order of about 2,000 to 3,000 milliseconds. So really you're talking about fat is a couple hundred milliseconds, water is a couple thousand milliseconds. So that's the range of T1 values that we're dealing with. And then something like muscle, myocardium for example, will have kind of an intermediate T1 time because it's composed of water as well as some macromolecules. And then on the T2 side, if you look at it, water has very slow T2 relaxation and therefore has a very long T2 time. Muscle, on the other hand, has a shorter T2 time, and then lipids have intermediate T2 relaxation time. Okay, so all of these things are kind of principles or properties of specific tissues themselves. Now, one thing, though, to be aware of is that we can cause some alteration to this, and specifically what you can do is you can cause an alteration to, for example, muscle by administration of contrast agents like gadolinium, which actually shorten the T1 relaxation time. So by administering gadolinium contrast, when it gets into your myocardium or when it gets into your blood, it will actually cause a shortening of what the T1 time was before you gave contrast agent. And so this is an example, of what it would look like for myocardium, the rate of recovery without contrast, and then myocardium if I gave contrast, and especially if I look at an infarct, which takes up a lot of contrast, you'll see that the T1 rate of recovery all of a sudden gets much faster. Okay, so let me skip forward here. So we talked about T1 and T2, and then I'll show you an example. So when you look at an image, you need to know how the image is generated. So the thing about MRI is I can make an image which is T1 weighted, which means that the signal intensity is a function of T1 characteristics, or I can make an image that's relatively T2 weighted, which means that the signal intensity is a function of T2 properties. And so by doing that, I can make the same substance, the same tissue, appear dark or bright. So here's an example of a pericardial cyst that you can see right over here. Right now, pericardial cyst is going to be primarily water. And we said that the T1 of water is long or short? Long, right? So water has slow T1 recovery, therefore has a long T1 time. If I do T1 weighted imaging, then anything that has slow T1 recovery will appear dark. Anything that has fast T1 recovery, like fat, remember we said fat has very fast T1 recovery, will appear bright. Now on the flip side, that same cyst, if I do it using a T2 weighted pulse sequence, and again with the T2 for water is long or short? It's also long, right? The T2 for water is also long, okay? Therefore the water has slow T2 decay, but with T2 weighted imaging, anything that has long T2 times gives you high signal. Okay, so that, again, you need to know what T1 weighted imaging does, what T2 weighted imaging does. More importantly, when you look at something and say, okay, well, what's the tissue characteristics of this, you need to know what sequence it is that was run. Okay, and so on a T2 weighted acquisition, since water has very slow T2 decay, has a long T2 time, water will appear bright. So the same tissue can appear very different depending upon what pulse sequence I'm utilizing. So first thing before I decide on what the characteristic of something is, I need to know what pulse sequence it is that's used to generate that image. Yes, Jeff?
So T1 and T2, are they basically inverses of each other? It's probably more...
It's not quite a direct relationship, but yes, the T2 time is always shorter than the T1 time of any tissue. And there's a indirect kind of inverse relationship, but it's not a one-to-one. Okay? So now, the other thing then, I touched on this before, is the idea of the gradient coils that we utilize. Okay? And so these gradient coils basically create a variation or distortion to the magnetic field. And so in the example I showed you before, if I'm applying a gradient in the head to foot direction here, this patient who's laying down inside the bore of a scanner, the head will see a slightly different magnetization than the foot will because I've applied a gradient such that there's a higher magnetization at the head than at the foot, right? Now again, the magnitude of differences we're talking about is very, very tiny. We're talking about 0.001 difference in 1 or 2 millitesla difference, right? So very small magnitude of difference, but it will cause the protons at the head to spin a slightly different frequency than the protons at the feet. Now I can use this to decide what slice I want to image. So let's say I want to image a slice at the location of his heart right here, versus I want to image at the brain, versus I want to image in the abdomen. Well, by moving a mouse, I'll tell the scanner, okay, I want an imaging slice that's an axial slice, for example, that's right at the level of his heart, right? Now the scanner can then determine, okay, based on the location that I want to image, the magnetization, if the magnetization here at the knees is 0, or I shouldn't say 0, but it's 1.5 Tesla, and it's a little bit higher up here, then it can calculate that at the heart, maybe the magnetization is 1.501 Tesla, and therefore, instead of spinning at 64 hertz, the protons at the level of the heart will be spinning at 64.01 hertz. So if I apply a radio frequency wave at that specific frequency, 64.01 megahertz, then only the protons that are within that slice at the heart level will get excited. The protons in the brain won't get excited. The protons in the legs won't get excited. So therefore then the signal that I receive back, if I only excite selective protons, the signal that I receive back will only be from the protons that are in the slice of interest. So this is the way by which I actually select the slice that I'm interested in imaging. So that's what's called a slice selection gradient. Okay, and that's what's shown here. Again, and you can pick whatever location it is that you want to be able to image. And then the next two encoding steps that occur are again from a second and a third gradient that's applied, and that's a gradient in the read or the frequency direction and a gradient in the phase direction. And these two get a little bit more complicated, and I don't want to get too much into the weeds of these two. But basically what that does is it causes, again now, within my x and y, not the z plane, now within my x and y plane, it'll cause protons to be spinning at slightly different frequencies along this frequency direction. And from that, when you receive signal back, you can use that information to actually help you encode where the signal is coming from. Is it coming from here, or is it coming from here, or somewhere in between? And then the last step is what's called the phase encode gradient, which then causes an actual net phase shift. Now, so with this one, this is the one that takes the most time to acquire in the phase direction. So you actually have to do multiple samplings where you turn on and off a gradient, but you do it with varying levels of severity. So that if you do a gradient, what will happen is that protons at one location will begin to have a net shift compared to protons at another location, and you can basically use this to try to solve where these protons were located along the phase direction. all right? And then when you take this information together and you plot it into what's called K-space, you actually are plotting basically the information about phase and frequency, and that's the raw data that you acquire in MRI. So it's not an actual image, it's raw data about phase and frequency information. So here's an example of a plot of K-space. You then apply a thing called a Fourier transformation to then actually allow you to generate an image itself. Now, a couple important things to keep in mind is that when you convert from K-space to image space to the image itself, every line of K-space somehow contributes to the image. So if I acquired, for example, the center lines of K-space, it's not like I get just the center of my image. Rather, the center lines of K-space actually give you information about image intensity. The peripheral lines of K-space give you information about the sharp details. When you combine these two together, that's when you get a high-quality image which has sharp details and has different image intensities. But notice, I could just sample the periphery alone, and I may then get very sharp details, but I won't have any differences in image intensity between one tissue versus another. Or on the flip side, I could just sample the center of K-space alone and reconstruct the image, and then I would actually have a whole image. But notice, I don't have very sharp details. I have differences between image intensity, but I don't have very sharp details between my image. And then there's other things that you can do where you can do 2D excitations, which is the bulk of what we do, or you can do 3D excitation where you actually excite a full 3D volume. So again, this is similar to what you would do in 3D echo, where you excite an entire volume of tissue and you image all at once. So there's two ways you can do imaging. You can do sequential 2D slices and stitch them together, which is, for example, what you do in CT, or what you do in some forms of 3D echo, where you take multiple subvolumes and stitch them together. Or you can do a true 3D excitation where you excite an entire volume of tissue and then image that entire volume of tissue. Now, I talked about the fact that the initial MRI techniques have been around since the 70s and 80s, but the limitations, the reason why they didn't really make it into cardiology and cardiac imaging was the issue that we've got two forms of motion that you don't have really to deal with if you're imaging the brain or the knees, and that's basically respiratory motion and cardiac motion. Now, the simple strategy to get around respiratory motion is actually to just try to tell the patient to hold your breath. For a lot of, for probably everybody in this room, that wouldn't be a problem, to hold your breath for 5 or 10 or 15 seconds, and we've eliminated respiratory motion. Problem is, for a lot of patients who have heart disease, they may not be able to do that. And then the other issue is cardiac motion. Remember, the heart is beating continuously, so there's movement that's occurring almost all the time. So there's very short durations of time in which the heart is not moving, right? And that's that period of time in mid-diastole between the T wave and the next P wave when the heart is relatively stationary. Well, what's the duration of that time? Well, it's probably on the order of a couple hundred milliseconds, right? And that's going to be variable depending upon what the person's heart rate is. So if they have a fast heart rate, this mid-diastolic time gets compressed, so it's shorter and shorter. So that's why one of the things you could do is you could try to slow down their heart rate. So that's what we do in CT lab. We give them beta blockers, slow down the heart rate to try to expand this period of time in mid-diastole when the heart is not moving, all right? But again, if you want to obtain a still frame image of your heart, what you need to do is you need to find a period in time when the heart's not moving and then only sample during that period of time. So you notice all of a sudden the efficiency of my acquisition has gone down tremendously. Because if I'm only acquiring data in this 200 milliseconds in mid-diastole and the actual R interval is 800 to 1,000 milliseconds, then I'm only actually acquiring data for 20-30% of the time. Right? So all of a sudden the total time it takes to do my acquisition is much longer. And that's why cardiac imaging takes a fair bit longer than if you're wanting to do non-cardiac imaging like the brain, where you can acquire data continuously. You're not having to sample only during a certain portion of the cardiac cycle. So as a result, since it takes longer to acquire, since we can only acquire data during a narrow window in the cardiac cycle, we use a strategy that's called segmentation. So what this does basically is we say, okay, so I'm going to acquire data only when I get to this point here in mid-diastole for that 200 milliseconds in time. I'll acquire as many lines of data as I can, but notice that doesn't allow me to complete my entire image. So what I'll do then is I'll say, okay, so I've obtained part of my image. I'm going to now go back, wait for the next heartbeat, wait again until I get that next period in mid-diastole, and then I'm going to acquire a few more lines of data. Then I'll do that again for the next heartbeat, acquire a few more lines of data, and then once I've done that, now I've generated all the lines of data that I need to generate my high-resolution image. But notice now, this one image is actually obtained over multiple different cardiac cycles. So as a result, if there's something different between this cycle and this cycle, it could cause a problem with my image generation, right? And so if the patient can't hold their breath between this cycle and this cycle, that could cause an artifact. If the patient has an arrhythmia, so they have a PVC or something else, that again causes the rhythm to be not exactly the same, then that could cause also again a problem with the image that I generate, because things are actually different. The different lines of data that I obtained are not exactly the same. They're not exactly symmetric. Okay, so those are all things that you need to be aware of when you're doing cardiac imaging, is being able to recognize when you see an artifact, what's the cause of it, what does it look like. And that's something that, as we have more advanced lectures, in our MRI lab, we have a weekly series of lectures that we do where we go into more details. We talk about the different kinds of artifacts, how to recognize them, and then figure out how to overcome them. Now, one of the ways that you can try to eliminate this issue is you can go to what's called just a single-shot acquisition strategy, where you say, okay, instead of trying to obtain a high-resolution image with a lot of lines of data, I'm going to compromise on my image quality and get a lower resolution image, but I'm going to do it in such a way that I can get all these lines of data within one heartbeat, right? So that's one of the things we can resort to in patients who can't hold their breath, who have a lot of arrhythmias, is go to these single-shot techniques, which again, you're compromising a little bit in the sense that your resolution is not as high, but it still allows you to get the image within one heartbeat, so you don't have the artifacts that occur from variability in just irregularity that occurs either because of arrhythmias or because of a patient's inability to hold their breath. And I'll show you an example of that. So on the right-hand side is a image that if you compare this image to the image on the left-hand side, you'll notice the details here are not as sharp, right? This is a slightly lower resolution image than the image here on the left-hand side. But notice the left-hand side image required more lines of data to obtain, therefore it took several heartbeats to acquire, whereas the right-hand side image was actually acquired within one single heartbeat. So it's a little bit lower quality, but it doesn't suffer from artifacts if a patient can't hold their breath or if the patient's having arrhythmias. Okay, so I'm going to try to wrap up here in the next 15 minutes or so, and the there's probably 2 or 3 concepts I want you to walk away with. One of these is the idea that MRI is unique in the sense that for the same slice that I'm interested in imaging, I can actually make the image look very different depending upon the type of pulse sequence that I utilize. So for example, if you look at this here is an image that's done using a gradient echo cine, whereas this is an image that's done using a steady state free precession acquisition. You'll notice the image contrast in these 2 cases is a little bit different. Notice the myocardium is a little bit grayer, where it's a little bit more black here. If you notice, the edges are not as sharp here as they are here. So that's because this is a faster sequence than this is. But notice I can also create that same slice location, but I can make it so that the blood appears black using a black blood preparation. Or I could use what's called an inversion preparation to actually make the area of infarct appear bright, to hyper-enhance. Or I could use something like tagging to actually cause tag lines to form. And I could see how those lines change over time to see actually where one specific voxel of tissue is moving over time. So the idea is that for any given slice, I can do multiple different acquisition strategies. And so as a result, you have to decide which ones you want to do, because you can't do them all, otherwise each patient would be in the scanner for 24 hours, right? Because if you want to do every single permutation and do every single slice location, it's just not feasible. So you have to decide what it is that you want to do, and then this is just the tip of the iceberg. There's many, many more sequences that we can run, such as flow sequences, and other. You can actually do sequences where you weight the image based on T1 properties, you weight it based on T2 properties, and therefore the images can look very different as well. So, but the bottom line is, when you look at an image, first thing you need to know is what kind of image is it, to be able to know, to make out what the tissue contrast means. Second thing I think is important to recognize is if you look at the hardware, so remember I talked about the idea of the gradients and the strength of the gradients. If you go back to 1985, what the strength of the gradients was on the order of about a few millitesla per meter. Now, from 2006 onward, the typical high performance gradients are on the order of about 45 millitesla per meter. So you can see there's been almost a 15-fold increase in the strength of the gradients over the last 40 years. And again, this allows you to be able to do faster and faster imaging. Now, let me try to bring this back to a little bit more of a clinical focus and a couple of points that I want you guys to recognize when you're on the floors taking care of patients. And there's two things I think you need to realize. One is the safety aspects with MRI. The other is the issue of gadolinium. Okay? Now, so gadolinium contrast, all right, that's a contrast agent we've been using since the 1980s. So it's been around for a long time. Gadolinium is an inert metal that's chelated because the metal itself, gadolinium, is very toxic. What's surprising is that for many years, gadolinium was used and there was no known side effects from it. And then around 2005 and 6, there were these cases that started cropping up. This is an example of a condition called nephrogenic systemic fibrosis, or NSF. And when it first came out, there seemed to be that there was a link to gadolinium, and so and you'll notice though that the FDA guidance with regard to use of gadolinium has evolved over time as we've learned a little bit more about this condition. And the first thing is that when it first came out in 2006, the warning was basically to try to avoid gadolinium in anybody with a GFR less than 60. But as they looked at these cases in more detail where it was reported to occur, they noticed that in the vast majority of the time, it primarily occurred in people with a GFR less than 30. So chronic renal insufficiency with a GFR less than 30. So that's when the FDA guidance was updated in 2007 to identify patients with a GFR less than 30 or patients with acute renal insufficiency due to hepatorenal syndrome, which were thought to be potentially at increased risk. And then the guidance, I think, has evolved further as more study has been done and we've gotten a better understanding. And so this is kind of what our current approach is. Basically, it turns out that the risk is going to be primarily in those with chronic renal insufficiency with a GFR less than 30. Obviously, if you have acute renal insufficiency, you can't really calculate GFR. So if a patient has acute renal insufficiency, that's also a patient you want to avoid, at least for the time being that they're having the acute renal insufficiency. The concern, obviously, is with repeated doses of gadolinium. And then an important statement that the FDA made, which is that there's no risk in patients with normal kidney function. So you cannot really develop nephrogenic systemic fibrosis in people who have normal kidney function. So I think that's an important thing to be aware of. And lastly, they recommend basically that all patients undergo screening. Now, it doesn't mean everybody needs to get a creatinine done. What it means is, though, that you need to at least screen by history for assessment of acute or chronic renal insufficiency. And then the risk factors are patients with diabetes, patients with hypertension, heart disease, smoking, obesity, high cholesterol, patients with a family history of kidney disease, patients over the age of 65, patients with urinary tract infections or obstructions, and then patients with systemic infection or autoimmune disease. Now the problem, so this, for a, if you're doing an orthopedic MRI service, maybe this might apply, where you could find some patients that don't have any of these criteria. Most of our cardiac patients, in fact, do, and that's why what we generally want for most cardiac patients is that we have a creatinine level checked. But it's driven by having these indications, but the reality is most of the patients that we're going to image are going to have these indications. Now, the last thing I want to touch on is the issue of safety, okay? And I was going to put this at the beginning of the lecture. I said, I'm going to put this at the end because I want people to go home with probably this message more than anything else, which is two things. The scanner's always on, so there's no such thing as, okay, I'm going to go in after, at nighttime and the scan, lights are out, I can just go into the room. No, the scanner's always on, and if you take anything that's metallic, ferromagnetic, into the room, it actually can get attracted to the scanner, okay? Now the thing with magnetic fields is, as it gets closer, the magnetic field gets stronger and stronger and stronger. So the object actually accelerates as it gets closer, and it becomes a projectile. And so there's been scenarios of people dying when somebody rushes into the room with an oxygen tank or something. So what we always say is, if you have a patient who's in the MRI scanner and they have a problem, they have a cardiac arrest or whatever, the thing to do is get the patient out of the room, and then you begin your resuscitation efforts, okay? So that's the one thing, if you know, any of you get called for a code and it's in the MRI suite, you know, God forbid that happens, don't go into the room with your stethoscope and everything else and go save the patient, because you're not going to save the patient. The first thing to do, take off all your metallic objects, get the patient out of the room, and then you can begin doing CPR and other maneuvers. So that's a key thing to keep in mind. The other thing is, you know, devices. I get called all the time with, oh, the patient's got this device, can we scan this patient or not? So there's actually, for most devices now, there's they have a labeling for the device, which you can find if you just go to the website for that particular device. And it will tell you, the labeling is defined this way. It's something that's MRI safe, and this is basically something that has no metallic components to it. So it's something that's non-conducting, non-metallic, non-magnetic, such as the plastic Petri dish. Okay, so very few things are considered MRI safe, completely MRI safe. There's things that are MRI unsafe, and these are items that are known to cause a problem in the MRI environment. And then most everything else gets labeled as what's called MRI conditional. And that means that it's an item that's been demonstrated to pose no known hazards in a specific MRI environment with specific conditions and uses. Notice we're not using the word safe. We're saying it's conditional in the sense that in the scenarios that we've tested it in, there's not a problem. Okay? And so those are devices that you probably can go ahead and safely scan the patient. But remember, and I'm going to kind of take you back here for a second. I don't know how many of you have been to Vegas? Not many? Or you don't want to admit to it? Come on. Yeah, come on. We've only got like 5 people. Well, you guys all know about the new city center complex that formed a few years ago, and there was a hotel called the Vidara Hotel, and it got some bad press. You know, there's a sign here, or an article here in NBC News, death rays at Vegas hotel causes the pool to heat up guest. Vegas hotel pool death rays burns tourist. So what was happening? And so I like to call this the Vidara effect, okay? So I've got actually a video I want to show you. Let's hope this video plays.
Taking a road trip to Vegas, be warned. The new MGM hotel there called the Vidara has been found to contain an extra you definitely don't want. It turns out when the sun's rays hit that curved building, it creates a 15-foot wide hotspot on the ground that is so brutal it can burn hair and skin and even melt plastic. Some unlucky hotel guests have been sent running from the pool area after being caught in what hotel employees are calling the death ray, a burning sensation from above. The hotel is rushing to fix the problem.
Okay, so what happened? So the issue is, and this gets to the issue with any device, okay, which is, let me go back here. You know, what was happening here at this hotel was that at a certain time of day, during a certain time of the year, the sun's rays were coming, and because of there's a lot of glass here and it's curved, that glass was causing those sun's rays to be transmitted directly to this one area in the center of the pool. Okay? Now that area shifted actually based on the time of the year and based on the rotation of the Earth's axis. But the issue is you can't possibly know all the possible scenarios that can occur. Because you could go to this pool 9 times out of 10, there wouldn't be an issue. But it's only certain times of the day, certain hours, under certain weather conditions, at a certain time of the year, at a certain location, where all of a sudden everything gets concentrated. And so that's what I think is important to keep in mind with devices. And actually, this is not the only building that this has happened to, interestingly, as I kind of digressed as I was preparing for this talk. There's another building, I guess, in London called the Walkie-Talkie Building, which also has a similar situation where, again, it's a couple hours during a day, during a certain part of the year, that the sun's rays actually become concentrated in one area. So if you're walking in that area, all of a sudden you can get zapped. All right, and so therefore that's why, remember, unless a device has absolutely no metallic components at all, you can't say it's MRI safe. What you can say is it's MRI conditional, and the way they define MRI conditional is they do modeling for a variety of different scenarios. So they try to say, okay, if the device is sitting this location, what if it's angled this way, if it's angled this way? What if the radio frequency waves that you transmit are this strength, different strength? So it's doing multiple permutations. You can't possibly physically test all those scenarios out. So most of the stuff now with new devices is by computer modeling, where they essentially model different scenarios, both for the device itself, different scenarios of MRI imaging scanning, and then from that determine what the likelihood is that there could be a complication. And so, for all these devices, it's impossible for anybody to know, to memorize all of this. So what I would say is, leave home with this message here. There's a website called MRIsafety.com. So if you have a patient on the floor, he's got a device, and you want to know, can this person get an MRI or not, just go to this website. And there's an area on the website that says, search the list. And you just type in the name of the object, Medtronic Revo pacemaker or whatever it is, and it will actually tell you whether the device is MRI conditional or not. And again, that doesn't mean that it's absolutely safe or not, but it tells you it's acceptable risk to try to do it, or it'll tell you the device is unsafe and it's not acceptable risk to do it. And also will tell you whether it's safe at 1.5 Tesla versus 3 Tesla, so if it's conditional. So I would say, if everybody writes this down and I get a few less phone calls, I wouldn't be too offended, with is this device compatible or not with an MRI. So let me leave it there and then just open it up. Any questions or comments from the audience? Okay, so what's that website again, guys? Yeah, MRIsafety.com. Yep. All right, thank you.